Hi, it's Emily from Respiratory Care, and we talked about the adaptive support ventilation for the intubated patient. Now we're going to talk about using the Hamilton C-1 for non-invasive ventilation. So in order to do that, we're going to go to Modes, and we have a couple of different options here. We have NIV, which is non-invasive ventilation, and we have NIV-ST, which is non-invasive ventilation spontaneous timed. So the type of patient that might require this mode of ventilation would be someone in a COPD exacerbation, perhaps someone in heart failure. So your provider will give you the orders for this particular setting. So let's go to NIV-ST. We're going to confirm that. So right now we have two different pressures here. We have the delta P, which is our pressure support level, and we have our PEEP. The total of these two is going to give us a peak inspiratory pressure that will generate a volume for the patient. So I like to start the patient out a little bit on the lower side just so they can get a feel for what that air is going to feel like blowing into their face. So here I am giving them 7 of pressure support and a PEEP of 5, so this would be a total of 12. And then we just set a backup rate for them of 12. Our inspiratory time we can adjust. So typically that's going to be 0.9 to 1 second. And then it will tell you over here on the I to E, they're having 1 second to inhale and 4 seconds to exhale. So that's something to consider, especially if the person has a condition like COPD. They need a little bit more time to exhale sometimes, and so you want them to be comfortable on the machine. Their FiO2 is the next setting, the flow trigger, which we can leave there at 5, and then our pressure limit, which we can also leave at 30. So let's start this up and see what it looks like when it's in action. So we're going to start our ventilation. So right now, because we have a backup rate in place, the ventilator is going to give them some backup breaths, but when they do trigger a breath, they will receive the level of support that you have dialed in, and we see the little purple arrow right below that yellow waveform indicating that the patient is taking a spontaneous breath. And right now I have the endotracheal tube hooked to this with the test lung, but you would attach your BiPAP mask to our blue flow sensor here. The other option, and let's put this in standby for just a moment. So we activated standby. The other option is just to do straight non-invasive ventilation. With this, you've got a pressure support and a PEEP, your FiO2, your flow trigger, and a pressure limit. However, you don't have a backup rate or an inspiratory time. So this is also an acceptable way to deliver non-invasive ventilation. Once you get the mask in place and you're administering therapy to the patient, if they feel like that they're not getting enough air, that's what I like to ask them. Do you feel like you're getting enough air? If they say no, then I can always increase their pressure support level some. And likewise, if you do have a blood gas available and you see that on the particular settings that they started out with, their carbon dioxide level is elevated, you can give them more pressure support. If their carbon dioxide level is low, then you can give them less pressure support. That's going to result in less volume being delivered to the patient. If we increase this, now we're at 17 total pressure being delivered, and so that's going to give more volume to the patient in that case. But again, you want for the patient in non-invasive to be spontaneously breathing. If they do go completely apneic, then that would be an indication for intubation. All right, thank you so much, and I look forward to talking with you in the next video.